Alrighty, we will get started. Thank you, everybody, for joining us tonight on our Special Olympics New York virtual health and wellness forums. I am Maddie Hasbrook. I am the Associate Director of Health for Special Olympics New York and your moderator for tonight. If this is your first time joining us, welcome. Our forums are a space for individuals with ID, families, caregivers, and the general community to engage with health-focused individuals or organizations, such as health providers or fitness specialists. The forums provide information and resources related to the health of Special Olympic athletes, while also focusing on bettering access to healthcare, education, and inclusive activities for all people with ID. Throughout tonight's presentation, we ask that you do stay muted, but feel free to use the chat and send in any questions, as I will be monitoring that. And there will be time at the end for questions as well. So I would like to introduce tonight's speaker, Dr. Stephen Sulkes. So Dr. Sulkes is a developmental pediatrician, professor of pediatrics at Golisano Children's Hospital in Rochester, a longtime clinical director for Healthy Athletes, and a past president of the American Academy of Developmental Medicine and Dentistry. He works to support Special Olympics athletes through pre-participation exams. He mentors medical students and residents and fellows to improve healthcare delivery and outcomes for people with developmental disabilities. And he advocates at the state and the local level for people with developmental disabilities. Dr. Sulkes founded the Rochester student chapter of the American Academy of Developmental Medicine and Dentistry, leading the training of medical and dental trainees in serving people with developmental disabilities. So tonight, Dr. Sulkes will be sharing information on taking charge of your health record. So Dr. Sulkes, I will pass it over to you.
Okay, so I'm going to be running the slides, and we're going to try this and make sure the next slide. I hope everybody can see this slide that says Own Your Own Health Record. And Maddie introduced me. Thank you very much. I am a very informal speaker. And actually, I'm going to take a second before I get into this to just find out about the audience. Maddie, can you just give me a quick overview of who's signed up, how many people, and what kind of groups are represented?
Of course. So we have a few athletes on the call, and we also have some people that work with Special Olympics, and then a few that look like they are part of the general disability work or people that are new to us. So we have a good mix of people tonight.
Okay, if there is somebody for whom the list that Maddie just gave doesn't apply, put in the chat what you are so we know. I want this to be meaningful and workable for the audience. The goal for tonight is to be very practical and to improve how healthcare is accessed and delivered for people with developmental disabilities. So let's make it that. Okay, so I'm going to move on with the slides. And the problem is that people, as I think as everyone on this session knows, people with IDD have problems with access to healthcare. People have health disparities, different from health inequities, but health disparities mean differences in health. Partly that's due to health inequities, as I said. Health inequities are differences in accessibility and access to care, and many of those barriers to health access can include problems with health literacy. All of us could be more literate in terms of our health to understand the conditions we have and the medicines we're taking. But one important element of health literacy is knowing how to work the system. And if you don't understand how health systems work, you're going to bump into them and you're going to get frustrated. And anybody who, and I'm betting that everybody tonight has been to an emergency room or been to a doctor's office or a nurse practitioner or physician assistant's office and and just had things not go the way they thought they should have gone because you didn't know you were supposed to ask for something. You didn't know you were supposed to advocate for something or tell somebody something. It's an awful thing. It's an unfortunate truth that the healthcare world is a domain that is populated by people who work in healthcare, and everybody who works in healthcare thinks they know how it works. And we forget that the people we're serving don't know how it works. So sometimes we just do a terrible job of helping people work through the system. So when I was first starting out, I graduated from medical school many years ago in 1978. But in 1968, a guy named Dr. Lawrence Weed in Vermont developed a process for making health records more organized. It was called the problem-oriented medical record. And everything in this focused on the problems that people had. And it could be all kinds of different problems. It could be headaches, it could be skin rashes, it could be stress at home, it could be allergies, but it was all based on problems. And this was great because it helped us organize information. And the way I was taught in medical school to write a note, because we still wrote notes by hand in those days, was to list out all the problems. And then for each problem, you would use what was referred to as the SOAP approach, SOAP, subjective, objective, assessment, and plan. And you would come up with a SOAP thing for each problem that the person had. And it was very helpful for a hospitalized patient, for example. A person in the hospital might have 8 or 10 different problems, and it helped us keep from forgetting stuff. And it helped us say, this problem is resolved. We don't have to keep writing about it, or this problem is still active, but we don't have to do anything about it for 3 days or whatever. Okay. Now, this was developed in 1968, and it became very widely accepted because it worked very well, but it focused on problems. That was a medical model kind of thing. Okay. And the idea at that point was that physicians are supposed to address the problems people come for, and it was not focusing on people's assets, people's differences, or how to help people adapt, to participate. It was a very medical model thing, but that's how it was. And as we developed electronic health records, that same problem-oriented approach persisted because it was kind of the industry standard. So just understand that this notion of problems dates back to the 1960s and has perpetuated through the years. So what is an electronic health record? And which is the same thing as an electronic medical record. And it's actually, I'm going to make a little joke here, but I'll come back to this later, but we are trying to avoid in our world of developmental disabilities the use of the R word. I think everybody knows what I mean. And in the old days, EMR meant educably MR. And so the electronic medical record, or EMR, often got confused with that other term. And I just want people to understand that if you hear somebody referring to the EMR, it's not an invocation of the R word. It's probably referring to an electronic medical record. Better to call it electronic health record, A, because it avoids that confusion, but B, also because it's about health. It's not just about what physicians do. Okay. But what this is if you know anything about computers, you may know something about databases. And databases are basically like a bunch of file cards, except and a standard classic database is a whole set is a set of file cards. But if you can connect those file cards based on things that are written on those file cards, it becomes a much more powerful tool. So the first table that electronic health record is going to have in it is the one with demographics. It's going to have someone's record number. It's going to have their name, their date of birth, their address, phone number, email, perhaps, but the basic demographic information, the identifiers for the individual. That makes sense. The second thing, though, is going to be the problem list. And I've made up a problem list here. This is just a sample problem list for an individual with Down syndrome. And you see that this person has trisomy 21, has intellectual disability, has hearing impairment, has hypothyroidism, which means an underactive thyroid gland, has congenital heart disease, has myopia, which means nearsightedness, and has flat feet. And that's this individual's problem list. Let people look at that for a second. And then I'm going to add a third table. Third table, I always ask you, do you have any allergies? And you might have allergies to dust or pollen, but you might also have allergies to medications where you develop a rash when you take something. And there's going to be a table in your health record that lists all your allergies. Then there's going to be a list of medications. And for this person, a thyroid supplement is there. There's a heart medication, and there's an antihistamine. So that's a fourth table. I'm going to tell you that there are probably 100 tables in your electronic health record. But these four are examples of things that will be in every version of every electronic health record. Another one might be equipment that the person uses. Okay, and you can see that this person has shoe inserts because of the flat feet, wears glasses, and has hearing aids because of the hearing impairment. So these are 5 tables in this individual's electronic health record. But what's cool about this is they get connected. So the first thing is that the demographic table connects usually through a record number to every other table that the person has. Okay. But you can imagine that for each of these tables, there's a long menu of things that needs to be filled in. Okay, and there might be hundreds of medications or thousands of potential problems. Okay, but for this individual, each of these tables linked by a unit number or a name is going to be linked back to that demographic table, because this is this individual's version of that table. In what I'm showing you now is that medications are specifically linked to problems or diagnoses. So this person's thyroid medication is directly linked electronically. They'll ask, what is this medication for? And they're going to say it's for the hypothyroidism. What's the heart medicine for? It's for the congenital heart disease. And similarly, this person takes an antihistamine because of the environmental allergies. So you see how medications connect to things on other tables. Similarly, the equipment connects to other things. This person, the hearing aids connect to the hearing impairment, the glasses connect to the myopia, and the flat feet connect to the shoe inserts. And so you can see how different things in different tables connect back and often connect back to that problem list. Now, saying that, in computer world, GIGO, or GIGO, I guess, because means garbage in, garbage out. And so if if this electronic medical record has bad stuff in it, inaccurate stuff in it, it's going to perpetuate, and it's going to be something that creates confusion and problems everywhere it goes. And I should mention, by the way, that electronic health records are great because of communication. The most two of the biggest electronic health record companies in the United States. One is called Epic, the other is called Cerner. Okay, you can, if I'm in a hospital in Rochester, New York, I can look up information from a hospital in California or Alaska or Hawaii that my patient was seen in, just by clicking a box and saying, clicking the Care Everywhere box that says, yes, this person has a record at a hospital in Honolulu, and you can see what happened to that person there and what that person's problem list is in that hospital, and you can make it all mesh together. But if garbage is in the system, it's going to spread throughout the whole system everywhere this person's record goes. One example of that is that in many hospitals, in the problem list section, instead of saying intellectual disability, it used the R word term. And we set out at our hospital to change that. And so I would say to my colleagues, I would say to all the medical students and residents, I say, when you see the R word in a problem list, just change it to intellectual disability. And people say, well, I don't want to mess with the problem list. Someone else put that problem in. I say, if you've got access to the problem list, you can adjust it, you can fix it. Okay. And in fact, a very smart colleague of mine worked with the computer people in our hospital to find all the places, all the problem lists where intellectual disability should replace the other term. And and very cleverly, they were able to go through and just replace it everywhere. It worked, but what it took was this colleague of mine who was motivated to do it, who knew how to talk to the tech people and how to talk to the people at the top level of administration to say, we're going to change everybody's medical record, everybody's electronic health record to get rid of this stigmatizing, unappealing term. And it worked. It worked, in a day once we got all the approvals in place. Okay. The thing is, that's great, but it's even better if the individuals look at their own records and make sure that what's in them is accurate. So let's talk about that a little bit. When you're in your health provider's office, there's going to be a computer. And take a second, find the computer in this room. I'll give you a clue. It's over there. Okay. Notice how the chairs are arranged here. The health provider is sitting on that little round stool. The patient and the people who came with the patient are sitting in those other chairs. But that screen, the computer monitor, is on an arm and it can be turned. Ask them to turn the monitor around so you can see what's on it. And if you have reading difficulties, ask them to read it to you. But it's really important to see what's on the monitor, to see what's on the problem list, to see what's on the medication list, to see what's on the allergy list, et cetera, et cetera. Because there may be things on there that are not right, that they're not true, or that are upsetting to you, or are offensive. Okay, there are times when things get put on that need to be put on so that health professionals can all communicate with each other. And so I'm going to give an example for myself. I wear hearing aids. And I asked people to please add hearing impairment to my problem list. So if I end up in the emergency room and I don't have my hearing aids with me, people who open my record are going to see that I have hearing problem. They're going to talk more loudly to me. Okay. If I, it's the same as if I had an allergy to penicillin. I would want them to know that. Okay. I'm constantly telling my my trainees that when a person has behavior that could be a problem, like pica behavior, putting non-food stuff in their mouths, or wandering where they're going to get up and walk away, that should be on the problem list, so that anywhere they go, people are going to be aware that this individual might exhibit a behavior that could be a problem in that health environment. I've had patients over the years who ate gloves, who ate, examining gloves, or things like that, because nobody knew to put the box out of the way. So I say to people, put that on the problem list. So everybody who sees this individual knows to be careful. So what I'm asking everybody to do is actually make sure that you know what's on that list, what's on the problem list, what's on the medication list, and you will get a summary at the end of every visit that comes out of the computer. And when you get home, you may not want to read it right there, but you may want to go over it when you get home to make sure you understand everything that's on it, because it's all the instructions and everything. And if you don't understand it, you can call back to the health provider's office and get clarification, or you can use a patient portal. And this is my chart. Okay, this is my personal my chart. Okay, and these are screenshots from my phone. Okay, Epic, every electronic medical record system, pretty much all the big ones have patient portals. The one from the system, the Epic healthcare health record system that I mentioned earlier, calls it my chart. And my chart, I have my chart from University of Rochester. I know I have patients here in Rochester who are served at University of Rochester, but also are served through the Rochester Regional Health System, and they'll have separate my chart accounts, separate patient portal accounts for each of those. If you have to actually ask for it to be set up, and then go through a couple of steps on your phone or your computer to make it work. Okay, but it's great. It's a really wonderful tool. And over here, what you see is the opening screen on the left, and on the right, this is the first thing that happens after you sign in. And you can see that there's a box for appointments and visits, and one for messages, and one for test results, and one for medications. And there's a message for me that says I can now see lab tests that I had done, and there's a test I'm supposed to do sometime later this month before I see one of my doctors. Actually, I'm supposed to have all these things done. Over here on the left is a list of my current medications with some, and I can choose which pharmacies they go to. I can transfer my prescription to a University of Rochester pharmacy. And it gives me instructions, then it lists all the medicines at the bottom. I didn't put all my medicines in right there, but the one you can see, Econazole, is a cream for a fungus rash that I have on my skin. Okay. And then the next one over is test results. And you can see that in June, I had some lab tests done. And if I clicked on any of those, it would tell me the results, and it would allow me to see comparisons of those results to what they looked like when I had them done previously. And then the screen on the right, the the part on the right shows a bunch of messages that I sent back and forth to various people. For medicine I was taking, for blood work I needed to have done. I got reminders that I should have things done. I got a message about the results. I'm able to send a message, and it would ask me which doctor or which health provider I'd like to send it to. I put in the message, and it goes to them. And it may take a couple days for people to respond to my messages, but they always do. So one of the national organizations that we belong to, which is called the Association for University Centers on Disability, or AUCD, created an activity for self-advocates through their Health is for Everyone action team, or HEAT, to help people own their own health record. And this is and this presentation was originally part of that a couple of years ago, but there's a toolkit that you see that is down at the bottom that you can, I believe, still download, with a whole lot of materials that might be helpful to you. But some of these things include healthcare access, being prepared for emergencies, healthy weight and nutrition, sexual and reproductive health, and mental health wellness. Okay. We actually did a session, I believe it was on Twitter a few years ago, with a group of self-advocates. Actually, this whole idea for me came out of a conversation I had with a set of self-advocates when we were talking about transitions from the pediatric world to the adult healthcare world. And we were talking about it, and I was asking, thinking about health literacy with people. And I just asked this group of people, have you ever seen your problem list? And half of them said, what's a problem list? And that's where this whole talk came from. But all of us need to be okay with asking questions and ask how these things work, find out how to access things. Okay. This stuff is hard to understand sometimes, and we need to be using plain language. And when you don't understand what the health providers say, have people rephrase it. If I've used jargon during this talk, have me rephrase it. Okay. Okay. People wanted support for speedy healthcare visits, and support for healthcare during emergencies and getting what you need right now, like a flu shot. Okay. Actually, telehealth is great. That's, when you can do your healthcare visit over Zoom, like this meeting. In many places, insurance covers it. But sometimes you need someone local to help you figure out the technology. And using the health record for self-care is super important. These are all things that came out of our discussion with self-advocates. So I'm going to use the rest of our time today to answer your questions. And so because I think it's more important for me to answer questions for you about how health records work and how you can use them well. Okay. I don't have any other slides after this except for our thank you slide. I'll just leave my contact information up.
Perfect. Thank you so much. If anybody has a question at this time, you can put it in the chat, or you can feel free to come off of mute as well.
Are there any questions in the chat from earlier? Oh, there we go.
I'll say somebody's raising their hand. Go ahead.
Go ahead.
Hi, I help people with eligibility for OPWDD services. And one of the issues that comes up is that either a diagnosis won't be on the problem list that I sent to the state, or something from a long time ago, or that isn't really, doesn't really have any, I guess, evidence, of a diagnosis is on the problem list, and both of those things can cause a lot of problems. And I don't know how to coach families to talk to their doctors to say, you know, we need to put autism on and we need to take bipolar off because there's, you know, we don't even know where that came from, kind of. Those are two really good examples of things that I've encountered. And I'm wondering, like, how can I help them talk to their doctor's office about this?
I think you just said it perfectly. I think you say to people, you know, there are things on your problem list that are missing or that are there that don't seem to be accurate and don't seem to, you know, be based in evidence. And I suggest that you talk to your doctor about cleaning up the list. I mean, that's as good a way to do it as any. Sometimes sometimes a primary physician will be uncomfortable adding a diagnosis that supposedly should be made by a specialist. And I'll give you a great example. And this happens. This happens a fair amount even in our clinic. Okay, and I work in a diagnostic clinic in Rochester. Somebody will make the diagnosis of autism spectrum disorder, put it on the diagnosis list for that day's visit, but forget to check the box that adds it to the problem list. It's as simple as checking a box. So the other thing you might say to the people you're working with is to say, who diagnosed the autism? And can you get them to put it on the problem list? Because sometimes when it's a diagnosis that requires some thought, it goes both ways, I guess. Diagnoses will get added that shouldn't have been added because someone just said it, and diagnoses will fail to be added because someone's nervous about adding it. So if the primary physician, the person who provided the problem list in the first place, is uncomfortable doing the cleanup, then the next step is to say, where did those things come from in the first place? Who made those diagnoses, and can we get them to clean up the record? Does that help? Does that answer the question for you?
Yeah, that's really helpful. I've seen your name a lot on paperwork. So it's nice to hear you. And
Sure.
it is very helpful because, like, you know, when we can't find the person who made that diagnosis, it really creates a problem a lot
Yeah.
of times with the state because they're so specific.
You
And
know,
so, you know, and I think families are afraid to offend their doctor, you know, to kind of boss them around to say this needs to be changed. And so I
no,
think
no,
that's where some of the hesitation is.
yeah, but people shouldn't be nervous. They're not bossing their doctor around to say, yeah, actually what they're doing is saying, I'm trying to establish eligibility for OPWDD services, and I can't do that because my record doesn't show what everyone knows is the case.
Right.
So it can be super helpful for people, and doctors generally want people to qualify. I mean,
Yeah.
so so checking a box on on an electronic record is not a lot of work. You know, it means opening the record, going to the problem list, you know, selecting something from a drop-down menu and clicking, you know, save, and that's about it.
Okay. Oh, wow.
Okay, it's not, this is not a complicated process. You know, one of the other things that happens, and this is just another nuance about problem lists, I guess, is that say I had a laceration. Say I cut myself and needed stitches. Well, should that be part of my permanent problem list, or should that just be there for a while? Right? So,
Right.
so sometimes people are uncomfortable clicking resolved when something is over. You know, saying resolve doesn't delete it. It just makes it stop showing. You can always pull up. Another example is sadly sometimes people get physically abused, and they might have a fractured bone, and then a year later another fractured bone, and a year after that a third, and each one of them resolves and gets clicked as resolved. But when someone's looking, they can show all resolved problems, and you see this person had 3 different bones that got broken. You say, "Oh wow, how did that happen?" And it can provide evidence that physical abuse was going on. So not everything has to stay active, but Dr. Reed would have told us add everything and then just inactivate it when it's not activated, when it's resolved.
Thank you very much. I appreciate this a lot.
Yeah, sure. The other thing about medication lists is that you can add subtle little data like person, and they can be linked to the problem list as well sometimes. So person can't swallow pills, unable to swallow pills could be a problem, and it results in people saying, "Oh, well, then maybe I should order a liquid medicine." You know, uh, you know, these are all things that can save hassle later. When they order the antibiotic and it comes as pills, and you have to call back and say, "No, change the prescription. This person can't swallow pills," or you need to, or can they be crushed, or whatever. These are all things that when it's used well, the data that are there can grease the wheels and make everything work more smoothly.
Okay, we have one in the chat. Kathy said, "Thank you for telling us that we can resolve items on our problem lists. I was wondering about that because I have a couple of problems that were resolved a long time ago."
Yeah, just have them check resolved, and they'll stop showing. Okay. Has anybody run into other kinds of things that they saw on a problem list that were bothersome to them?
Paula said, "When my son arrives at the ER, the hospital has medications from years ago that were discontinued."
So they're still showing up in the medication list because they never got taken away. So that's another thing to say to the health provider. Say, "Yeah, I'm not taking that anymore. Could you please delete it from my medicine list?" That's and the so one of the other, it's a good news, bad news thing. I'm going to say it this way. Because all these health systems talk to each other, I was saying between University of Rochester and Rochester Regional System, for example, uh, I can have a patient who hasn't taken a medicine for years, but it was prescribed at that other hospital, and it's still on. It never got deleted from that hospital's list, so it pops up as a question: is this person still taking it? When in my record, even though it doesn't show up in my record, it's showing up in somebody else in the record from across town, where they haven't been seen in 5 years, and it just never got deleted over there. I can't delete it from their record, but I can make sure it doesn't show up in mine. So I can only control the record that's the open in front of me, not the one from across town, unfortunately.
So that relates to what Kathy said. She said, "Unfortunately, sometimes medications are removed but show up again in the future."
Yeah, yeah. So that's it gets to be it, I've had that happen with patients where they came back and, I always do the medication reconciliation, and I'm always finding myself saying, hey, okay, I'm pretty sure that this one from 3 years ago from that other hospital is not active. Okay, I'm just going to ignore it,
Are there any other questions? Take a last look at the chat.
Actually, just going to say one other thing.
Sure.
While we're talking about it, okay, that hospitals all over now are becoming much better at checking at not necessarily believing that you have penicillin allergy. Okay, there are lots of times people get rashes after getting an antibiotic, and they report, I got a rash, and it gets marked as allergy, but it's not really an allergy. It was a rash that wasn't an allergic rash. And so now at our hospital, when a person is in the hospital and has an infection that you might use a penicillin product for, they can actually call in some allergy people who will test to see whether you really are allergic to penicillin or not, because then it opens up the opportunity for a very helpful antibiotic that you might have thought you couldn't take. So that's another one of those it's an allergy thing that gets perpetuated over time that sometimes gets taken away. It's nice.
I think we are all set. So if you will go to that last slide.
Yep.
So I want to just thank you all for being on tonight, and the video of this virtual recording will be on our Special Olympics New York YouTube page if you would like to share it with anybody else, or if there's anybody that wasn't able to be on live tonight. I will also at this time send a Microsoft link through the chat, and you can use that form to submit any other questions that you didn't get a chance to today, or that maybe you weren't comfortable asking on our live offering. I also would like to thank Care Design, who is our sponsor for these virtual forums. And I just want to, again, thank you all for joining tonight. And we hope to see you at our next forum on September 17th at 6:30, which will be covering understanding and planning for the needs of older adults with ASD. So I hope you all have a great night. Thank you.
Thank you, everybody.
Thank you.